Hello, I'm Aaron Lohr, and this is the Endocrine News Podcast. Seems like everyone is talking about artificial intelligence and machine learning these days. Why should we be any different? Today we're talking about machine learning and how it may help diagnose metabolic dysfunction-associated steatotic liver disease, or MASLD, M-A-S-L-D. Joining me to talk about it is Dr. Christos Mantzoros, professor of medicine at Harvard Medical School and editor-in-chief of the journal Metabolism. Dr. Mantzoros and his team presented their work at ENDO 2024, and their abstract was titled Accurate Machine Learning-Based Diagnosis of At-Risk MASH and MASLD Subtypes Using Categorical Gradient Boosting and Select Clinical, Biochemical, and Metabolomic Measurements, Building Highly Robust Models with Few Variables through a Multinational, Multicenter, Biopsy-Proven Cohort. Thank you for joining us on the podcast today, Dr. Mantzoros.
Nice to be here, Aaron. Thank you for the nice introduction.
What is MASLD and how is it related to steatohepatitis?
Yes, that's a mouthful, right? So it's a new term. We used to call it non-alcoholic fatty liver disease until recently. Before that, cryptogenic. And there is a reason for that. So this is a disease which is very really prevalent. 30% of the population today have more than 30% fat in their liver. And this is abnormal. More than 30% of the population today have more than 5% fat in their liver, and this is abnormal. This may lead to steatohepatitis, and we'll talk in a minute how, or cirrhosis and liver failure. In the past, we did not know what the cause was, and that's why we would call it cryptogenic. Crypto means hidden to us. More recently, we found that this was not associated with alcohol, thus the name non-alcoholic. But today, we realize that this is a dysmetabolic state. So insulin resistance, more fat in our diet, obesity in our society leads to more fat in the liver. And this is what we call dysmetabolic steatotic fat liver disease. 30% of the population. So similar to any other, deposition of fat in any other organ in our body, think about vasculature and cardiovascular disease, muscle. Deposition of fat leads to macrophages, our immune cells, going there and trying to remove it, to phagocytose. And this leads to inflammation. 20% of the case, this cannot be removed and leads to a permanent, long-term inflammation. And this is steatohepatitis, hepatitis indicating the inflammation. 20% of people over a period of 7 years will move on to develop fibrosis, scarring. And this is what in cardiovascular disease we call fibroscarp, right? In the liver, it is cirrhosis. And this can lead to liver failure and liver transplants. So at this point in time, MASLD is very quickly becoming the top cause of liver failure and liver transplants in our population. This is a very, very important problem. And as I told you earlier, it travels together with cardiovascular disease as part of the cardiorenal metabolic syndrome.
What are some other health risks associated with MASLD and metabolic-associated steatohepatitis, or MASH?
So this is a very good question. As the new member, the new kid on the cardiorenal metabolic block, now in metabolism, we realize that there is a number of diseases that have the same roots and travel together. So obesity, which is becoming more and more prevalent in our society, insulin resistance, ectopic fat deposition, leads to certain diseases that travel together. So if there is more fat in muscle and people have genetic predisposition, they develop diabetes. In fat, MASLD. In the cardiovascular system, we talked about it. in kidneys, chronic kidney disease. And if the process continues for many, many years, this would lead to obesity related malignancies. So if an angel would come to our world to make obesity disappear, 30% of cancers would disappear. This is very important. And even more long term, neurocognitive disorders, Alzheimer's, and mental decline. So all these go together now as part of a cardiorenal metabolic syndrome. Now, what was the problem with muscle? Why a lot of people out there don't know about it or don't think about it? Even professionals, our colleagues, until recently, were not thinking about it. So in my clinic, in our diabetes clinics, we said that muscle travels together with diabetes. 70% of our diabetic patients, on average, have steatotic liver disease. Until recently, we were not testing a lot about this. Why? Number one, we did not have the tools to either diagnose or treat. And number two, most of the time, the disease is asymptomatic in early phases. And when we discover it with cirrhosis or liver failure, it may be too late for an endocrinologist to intervene. It is in the field of hepatologists or gastroenterologists. But now we realize that the roots of the problem are squarely in the endocrinology and metabolism field. And we own it. We need to diagnose it, detect it, and treat it. So it's our problem.
So let's talk about that diagnosis a little bit. How are MASLD and MASH typically diagnosed, and what are the challenges involved in making that diagnosis?
This is work in progress. Until recently, there was nothing available to us. Ultrasounds detect fat in the liver, but one has to have more than 30% fat in the liver. So they are not sensitive enough for people who are in the category 5% to 30%. There is blood tests like ALT, AST, liver tests, but again, these are not as specific. So what we have developed in the past few years, we call them non-invasive tests. So we put together panels of laboratory tests or physical examination signs in order to create non-invasive tests. So the most widely used one today is called FIB4. And in our hospital, we have put it as a default to pop up every time we order a CHEM20. However, this is far from being a perfect test. So the sensitivity and specificity is good enough to alert us to the fact, but not clinical grade in terms of the 95 or more sensitivity or specificity we would need to have a diagnostic test in the clinic. So there is a gap there. Another area of research is to diagnose it with MRE, so MRIs with elastography, which is expensive test and not widely available. Not everybody can have an MRI if we are talking about 30% of the population. And finally, the gold standard is a liver biopsy. But we cannot do liver biopsies in 30% of the population. It's impossible. And even if we could, we would have only in the USA 14,000 excess deaths and hundreds of thousands of hospitalizations. It's impossible. So we need to find a liquid biopsy, a blood test that would have the sensitivity and specificity of liver biopsies. So, and this is what we started developing. Others are also doing this in one or two other medical centers in the USA. The Europeans are also trying along these lines. We are trying to create large databases and biobanks with hundreds or thousands of biopsy proven data and samples. And then we try to get the best and easiest to measure blood tests that would correspond with liver biopsy. But we realize that there is so many thousands of molecules that circulate in our bloodstream. In our routine blood tests, we test only a few of them. But if you can think about metabolites, metabolomics, proteins, proteomics, lipids, lipidomics. We are talking about thousands of molecules. And clinical data these days in our electronic health record is enormous, right? So it goes beyond the capacity of our brains and our usual statistical models to put all these together and try to find what is the best combination to correspond with liver biopsy and make a prediction. So we are leveraging now machine learning and artificial intelligence to put together huge numbers of data for a relatively small number of people. So 1,000 people, but thousands of molecules, and try to come up with 3 or 4 entities, right, members that would create a panel. This is work in progress, and this is what we are going to discuss during the Endocrine Society meeting. This is even more timely because the FDA just gave provisional approval to the very first medication for NASH. We had no medication until recently. We were using off-label medications for people with obesity and diabetes for specific stages of NASH. So this new medication now that is coming to the market, the FDA provided provisional approval without linking it to liver biopsy. And there is no guidelines and no studies out there how to diagnose before you use this medication for these specific stages of muscle. So what we are going to present at the meeting is, first, we are going to focus on F2, F3. These are the 2 stages that this medication is approved for, and present what are the sensitivities, specificities, and predictive value of the established tests one by one, and then how we improve it using artificial intelligence. And then all other tests in clinical trials today are indicated for phases F2 to F4, different bucket, different category, different analysis, established tests, and then the novel tests. So this is the value we are trying to add to the field. We need a new diagnostic. We want it to be simple. We want it to be able to be added to the automated chemical analyzers we use in our hospital laboratories today. And with a blood draw, we should be able, with more than 95% sensitivity and specificity, to tell who is at high risk and who can be just followed. High risk can be treated and who can just be followed.
So we're all excited to hear more about the study you're presenting at Endo. Can you tell us more about it? How you use machine learning algorithms to create these diagnosis models?
So we have started utilizing data from a large database that we have here at Beth Israel Deaconess Medical Center and Harvard Medical School. We created artificial intelligence, and we are going to announce a new panel with only 4 components. 3 are clinical and laboratory tests we do every day, and 1 is a novel test that, when added to the 3 that we have available to us, increases sensitivity and specificity to more than 95%. This is work in progress, as I said. So our population is primarily Caucasian. So what do we need to do next? And what we are doing now as we speak is we plan to go broader and we plan to go deeper. So broader means we need to replicate, validate our findings in a Northern European population. So we are collaborating with the German Diabetes Center, and we are testing their samples blindly. So hoping that we'll validate to the decimal point what we found in our population. We are expanding also in the Latino population in collaboration with Mexico and Colombia, South America. Why? Because the Latino population has a certain genetic predisposition that makes people in South America slightly more prone to have steatotic liver disease, which is somewhat different from the general Caucasian population. So we may have to modify the panel for the Latino population. This is regarding diagnostics. But we also need a test for prognosis. So prognosis of medication what is going to happen to someone, right? We know the physiology of the disease, but can we predict who is more prone to develop steatohepatitis, inflammation, who is more prone to develop fibrosis, who is more prone to develop liver failure? Because this is the population we need to focus on. And then the third field, going in a logical order, right, is if we put people on medications, like the newly provisionally approved medication or other medications that are out there being tested. So incretins, GLP-1 analogs are being tested. So can we predict who will respond to a specific medication and who is not? Because not everybody is going to respond. And this will help us keep people on high dose for a long period of time for those who respond. And of course, switch to a different medication if someone is not responding. So diagnostics and prognostics. There is a lot to be done. And we are grateful to the Massachusetts Life Sciences Foundation, which has been funding this work. And we just renewed our funding for another 3 years through an innovation grant from the state of Massachusetts, in collaboration, of course, with companies that are expressing an interest and other funders, foundations. These are expensive studies, take a lot of time, but we are making significant progress. And this is a race to get to the bottom line at this point. Closing, I would like to summarize by saying that this is a prevalent disease. We did not have good diagnostics. We did not have any therapeutics until recently. It's an unmet clinical condition. But we started understanding now what it is, and this is the beginning of addressing it. It's a dysmetabolic state linked to obesity and insulin resistance, which is the epidemic of our society. And with the better understanding, we'll develop better diagnostics, and there is more medications in the pipeline. So now that we will have diagnostics and medications for the disease, we need to think more about it. And when we see diabetics, obese people, people who have the metabolic syndrome, we need to screen. Think about it, screen, and treat.
Dr. Mantzoros, it was an absolute pleasure having you on the podcast. The work you're doing is so important, and we really look forward to maybe following up with you later to see how it's going. But this is just fantastic.
Aaron, thank you very much for the opportunity, and it's very nice to be with you.
I hope you enjoyed hearing more about MASLD, MASH, and how machine learning may play a part in diagnosis. Thank you again to Dr. Mantzoros. If there's a topic you'd like to hear us cover on the podcast, let me know by emailing me at podcast@endocrine.org. That's podcast@endocrine.org. We'll be back soon with another fascinating dive into the world of endocrinology. Until then, thanks for listening.
Endocrine News podcasts are a free service of the Endocrine Society. To learn more or to become a member, visit the Society's website at www.endocrine.org.